visit, she had a child debridement, and then 3 days after the child debridement, we put her in a wound vac. And the delay, usually those patients after the surgery can go directly in the wound vac, but what happened was nobody available to do the transition, so we waited 3 days, and then we were able to put her in the wound vac. And of course, we didn't have equipment. That was the other thing. It was kind of the weekend, so we had to order the equipment and wait a few days until Monday to get the equipment here. And then we put her in a wound vac and start changing. She started getting therapy, moving around, and then we sent her back to the nursing home to continue her rehab and with wound vac orders. The treatment was set up to 125 millimeters of mercury. Continuous, so she had this attached to her 24 hours a day, and we did dressing changes on Monday, Wednesday, and Friday. And pretty much the idea is to remove everything, clean the wound, make sure that it's not bleeding. That's the main, we wouldn't say problem, but the main issue is if there is any complication with the bleeding. So this is very particular, this treatment, really careful with patients with anticoagulants and clotting factors problems. So what else? You don't supposed to put this directly to bones, to tendons, on osteomyelitis. Patient with osteomyelitis, we have to be careful. We have to start treating the osteomyelitis first before we go into the wound vac treatment. We use, there is a different, a wide dressing that is moist in case that we have like tendon exposed or fascia exposed. We want to protect that. We want to keep those structures really moist, so we don't want to get them dry. It's wonderful. I absolutely like this. It works really, really good with the patients.
Spring.
Oh. Do you guys have any questions so far?
I have a couple comments. You know that slide that you showed where you measure?
Yeah.
That would be also, yeah, that one. A way to culture. You know, can you comment on culturing? Because you're supposed to clean off the wound and go to the leading edge of the ulcer to get a good swab for culture.
Yeah, usually when we culture the wound, if there is any suspect of infection, we clean it with saline solution. We try to get rid of all the debris and clean it as much as we can, and then we go to with the Q-tip and we go all over the deepest part of the wound and get try to swab all the wound and get as much as we can on the tip. Q-tip.
One other thing, when I first got into my pathology first job, it was in a hospital that had a big wound care program. And so, they would send specimens for histology for just, diagnosis part. And one out of every few hundred, I would find a squamous cell carcinoma. It's probably, I'm not sure what causes it, but it could be chronic inflammation, then create some kind of changes in the DNA, which then produces the squamous cell, and then I guess you end up with a ulcer that just won't heal. And that's when they do the biopsy, and here I got hundreds of biopsies, but out of every few hundred, I would have a squamous cell carcinoma.
Always a wound that doesn't heal on the skin, you would get worried about some sort of skin cancer, even a little small one that people have sometimes, little unhealing wounds on their faces and stuff.
In your handouts, we have 2 case studies again about the use of the wound vac. And this is is one of them. This is the first one. This is the second one. It's a 95-year-old patient that she fell at home and she stayed down for 3 days. She wasn't able to get up and nobody found her, and after 3 days then she developed a sacral ulcer. When she went to the hospital, then they found she had a humeral fracture, she had a pelvic fracture. The wound was a stage 4 covered with necrotic tissue. The culture that they did in the wound was positive for MRSA. The patient, the idea was to do a surgical debridement, but the patient refused. And so they cleaned the wound, tried to do chart debridement, mechanical debridement, and then was put in the wound vac. So this was the wound at admission. And
Martha, do you cut your phone to fit just where the wound itself is? The phone, the black
yes,
foam piece?
yeah, you cut it smaller than the wound, because when you put the compression, the suction is going to suction. The foam goes all the way flat and bring the wounds of the edges together. So it looks really small when the foam is on. The patient here, I don't know if you see really well, but he's laying sideways, and this is the head. This is the feet. So he's laying sideways. It's a pretty big size wound. The day one, when they started the wound vac, was 9 by 8, like 2.5 centimeters. How do I point with this?
I don't think it works on that
Okay.
TV screen.
So, to emphasize what Tisha said about how we measure wounds, the patient is laying sideways with the head here and the feet here. We measure length from the head to the toe, so it's gonna come from here to here. So we're gonna kind of have a mark here. Go from here to here. And width, I think we go for the red top part there to the bottom. And the depth, we try to measure as much as we can, even with the necrotic tissue in it. There are some wounds that even they have necrotic tissue, they still have some depth. So we measure that, considering that most likely the wound is way more deeper after we debride it. They did a little bit of debridement, they put some medication, and they put the wound back. And if you see immediately, the wound looks a lot smaller. One thing that I want to emphasize, when we put the tubing, the standard of care for this, we don't put the tube directly on the wound, because then most likely the tubing is going to create pressure also. So we use a technical bridging technique where we extend the foam to the side of the hip. So instead of going directly on the sacrum, we put the foam on the sacrum, but we extend the foam to the side, to the gluteal area, and then we attach this on the gluteal part. So there is no pressure from the tubing. And of course, we have to watch the tubing, because sometimes the tubing create pressure areas too. The idea with the wound vac was to provide the healing while the patient probably will change her mind to do the surgery, but since they saw the patient was doing better, then they kept using the wound vac until the wound was completely healed after 71 days. The next one, let's see. This one was a 74-year-old female with bilateral below knee amputation. She was an end-stage of renal disease, coronary artery disease, peripheral vascular disease, hypertension, COPD, hepatitis B and C, vancomycin resistant variant, sorry. She had surgery, bilateral below-knee amputation, coronary artery bypass, aortic valve replacement, and she was on anticoagulation therapy. And the patient was admitted with a non-stageable wound, I would say, you don't know what stage it is, on the residual limb. And after doing a surgical debridement, then the patient was placed in a wound vac. They put it 125 millimeters of mercury for the first 48 hours, and then it went intermittent, on and off. I think it was 5 minutes on, 2 minutes off. And with dressing changes every 3 times a week. And so it takes 45 days to heal.
Do you send those patients home, or do they have to stay in the hospital?
Yes, when we set up, what we do here, we set up the patient with a wound vac, and then if they're ready to go home, we set them up with outpatient services. They can come, or they can have home health for the wound dressing changes and the therapy at home. It depends. They have, if the patient is very active, there is a portable unit that they can carry. It's like a nice purse. It's a really tiny. The unit here is really big.
That's a great purse, Mark.
It is. It's not heavy. It's really
Very
big.
expensive purse.
And so they can get on with their lives like they usually do, and they just come to therapy 3 times a week. And what we do is clean the wound, make sure there is no maceration tissue in the peri-wound. We check for how much drainage is in the container, what kind of color it is, if she's having any pain. It shouldn't be painful. It should be really comfortable. Okay. No questions on that? Another treatment that we use is the mist, the non-contact ultrasound. I don't think I gave you any handouts about it. Oops. Okay. So the idea with the non-contact ultrasound is to stimulate the fibroblast activity in the wounds, clean and do a little bit of debridement in the wound, and stimulate the proliferative phase of healing. This is pretty much for any wound that is any wound, especially I like them for patients with diabetes, diabetic wounds or wounds that the arterial wounds that are extremely painful. And it's really nice because it's not invasive, and you are not touching the patient when you're doing this. Many times I combine the mist, the non-contact ultrasound with the wound vac when I do the dressing changes. I like to do this one too. Use for venous ulcers. So, Tish, you want to be my pick? So we use saline solution here. This comes with a kit, sterilized, and the attachment here comes in the kit with a saline solution bottle. I have extra saline here. And we go according with the wound size, then we decide what kind of therapy we're going to use here. If it's more than 10 centimeters, so we use less than 10 centimeters, we use 3 minutes of this.